Review the Quizlet I made about mood disorders and anxiety. Now, something you need to know is anxiety is healthy and normal. Okay, it's when it gets out of control that it's a problem. So, anxiety disorders are like a class of disorders that are marked by feelings of anxiety and excessive apprehension. Okay, so in other words, anxiety is good, but if you have an anxiety disorder, that's going to interfere with your effective functioning. Okay. And it feels like life threatening to that individual who has an anxiety disorder. So, some of the things that put people at risk, or older adults, I should say, at risk for anxiety include psychosocial stress, having depression, have cognitive impairment, or any type of physical illness. Um, is it necessary to have an intervention in anxiety disorders? It may be to prevent harm towards themselves or aggression towards others. So here are the different types of anxiety disorders. One is just called generalized anxiety disorder. There are phobias. There's post-traumatic stress syndrome and panic disorder. Okay. So generalized anxiety disorder is persistent, it's unrealistic. Um, Not to the patient, but it seems like their anxiety is out of proportion. Okay, so they have excessive worry about two or more circumstances for 3 or more months. It develops slowly and it's chronic. Then the next disorder we're going to talk about is phobia disorders. This is like people that are afraid of heights, afraid of spiders, and the fear could lead to avoidance of extreme anxiety, and it interferes with their responsibilities and routines. Somebody when I was in college had agoraphobia and she couldn't go outside. She couldn't do anything. It really hurt her social life. So those are phobic disorders. The other disorder is obsessive compulsive disorder. And what happens in excessive compulsive disorder is they have anxiety. It's kind of like a cycle. So they have anxiety and they do these compulsions, whatever the compulsion is, washing their hands, vacuuming their room. Some have rituals they have to do, making their bed 100 times. But the compulsions help reduce the anxiety, and then they get temporary relief. And then they start obsessing again. Then they have more anxiety, compulsions, relief. So that's like the cycle with OCD. Okay, so how should the nurse assist a patient? So allow time for the compulsive disorders, like wake them up earlier or have them have a later bedtime if they have to get their compulsions done early on. Post-traumatic syndrome. Okay, so post-traumatic syndrome occurs when somebody has haunting memories or nightmares. Okay, they could have jumping anxiety, have insomnia. It happens within 3 months of the event. Okay, so like our military are very prone to this. So they have, like, the signs and symptoms include flashbacks, avoidance of stimuli associated with trauma. They could experience persistent numbing responses, and then they have increased arousal when they're having symptoms. Okay, so remember, it's within 3 months of the event. So to treat anxiety disorders, okay, you're going to use some type of they may use some type of anti-anxiety med. They could have cognitive behavior therapy, learn to manage stress and teach the family how to cope with the symptoms. Benzodiazepines are prescribed with caution for anxiety because they could result in tolerance and dependence. You can't drink when you're on them. They must be tapered off. So the two drugs that must be tapered off out of all the drugs is alcohol and benzodiazepines. If anybody stops cold turkey, they're at risk of dying. They could have seizures. So they have to wean off medications. Okay. Buspirone, this is an anxiety agent that is non-sedating and there's less risk of dependency. Can't drink grapefruit with it. Can't stop abruptly. Okay, another drug that needs to be tapered. Takes 3 to 4 weeks to reach therapeutic effect. Okay, so So some of the other things you can do if you have an anxiety disorder, exercise, like move large muscle groups, okay? Like walking, running, taking a warm bath or shower, listening to music, talking to a friend you like, anything that is calming to you. So the physical signs and symptoms of anxiety, I think we've all been there, right? Tachycardia, diaphoresis, restlessness, blood pressure may rise, dry mouth, dizziness, etc. You want to maintain a calm and reassuring attitude with your patients. Anxiety is contagious and can spread rapidly. That's why I always tell you, if your patient is having trouble breathing, stay with them and remain calm, because your patient's going to get super anxious, okay? And get the head of the bed up. All right. So if somebody's having a panic attack, they may develop respiratory alkalosis, okay? So they could get like numbness around their mouth. Okay, have the patient breathe into a paper bag so that they'll be rebreathing the CO2. All right, so now we're going to talk about mood disorders. Okay, we're going to switch to mood disorders. So they're sometimes misdiagnosed. Okay, the first one we're going to talk about is mania. Now, mania can be by itself or it can be part of bipolar. Okay, so it's pressured sleep, speech, flight of ideas, don't sleep, inability to concentrate, labile behavior, which means moods are up and down, increased goal-directed activity, so impulsive spending, hypersexuality, gambling. Oh, that's like impulsive spending, but gambling could be one too. Joking, and aggressive behavior. They could have a flight of ideas, so it involves abruptly switching conversation from one topic to a next. How should you communicate? Focus and redirect the conversation if your patient is manic. If you have a patient that is a manic patient that's experiencing like hypersexuality and they're dressing provocatively and it's not appropriate for the situation, take the patient back to their room and help them pick something appropriate. What's the hallmark cues of bipolar? So bipolar is mania and depression together at different times. So decreased need for sleep and racing thoughts are usually the first cue of bipolar disorder. All right, so bipolar, episodes of extreme sadness, hopelessness, helplessness, with periods of extreme elation and hyperactivity. Okay, so they can have frequent mood swings. And it's caused by an imbalance of neurotransmitters in the brain. I mean, the patient can't have it. Can't help it, right? Something they were born with. Lithium is a drug that has been used for years to treat bipolar. It needs to be taken with meals or a glass of water. Has a narrow therapeutic range, which means when you hear that, it means highly tested. Lithium levels must be determined 8 to 12 hours after the first dose, then 2 to 3 times per week for the first month, then weekly, then monthly. Narrow therapeutic range, right? And then with lithium too, you have to be careful because it's a salt and it can result in diuresis. You have to worry about dehydration when it's hot out. All right, so there are mood disorder medications. Sometimes they use anticonvulsant medications off label to treat bipolar. So with data collection with anybody with mania, okay, remember, mood is subjective. So you can't tell me what somebody's mood is. It's subjective. They have to tell you. Affect is objective. Affect is something you observe, okay? You're going to collect, their physical signs and symptoms. Are they sleeping? Do they have hypersomnia, meaning falling asleep but waking up 2 to 3 hours later? All right. So what intervention is going to help a patient's nutritional status? You can imagine that if you have mania, you're going to burn more calories, but you have to provide high calorie intake and offer protein drinks every 1 hour and provide high calorie foods that the patient can take with them, like chicken nuggets, like finger foods. Interventions, always keep the patient safe is going to be your number one priority. Administer the medications, hopefully provide for a restful sleep, keep it quiet, and therapeutic communication set limits, focus, and redirect the patient. Major depression, let's talk about that. It's the inability to feel joy, pleasure. You don't enjoy things you used to enjoy, okay? So you have no more, you don't experience interest the way you used to in your daily activities. So these are the signs and symptoms: overwhelming feelings of sadness, waking or loss, okay, not attributed to anything, sleep disturbances, sleeping too much or too little, fatigue, loss of energy, you feel worthless, you can't make a decision, suicidal thoughts. People with depression can have psychomotor retardation, which means slow speech, thought processes, and they can be irritable. So the diagnosis, when they have 5 symptoms for 2 weeks, okay? Now they have to rule out hypothyroidism. You're going to learn about that next semester, and chronic fatigue syndrome and post-chronic stress. It could be a dual diagnosis, like somebody could have substance abuse disorder. Is depression normal finding in older adults? No, it's not. Mayo inhibitors are highly tested. It's a type of antidepressant. You have to avoid tyramine foods and meperidine because the side effect is going to be malignant hypertension if you don't. Okay, so they should be told to go to the ED if they have a headache. And food and drug restrictions remain 2 weeks after the drug is DC'd. Okay, so when we used to give meperidine, I would always check the chart to make sure my patient hadn't had a Mayo inhibitor within 2 weeks. All right, so tyramine foods include aged cheese, cured meats like salami, pepperoni, sauerkraut, soy sauce, shrimp, Chianti wine, beer, fava beans, yeast. The trick question I've seen on ATI is cottage cheese does not contain tyramine. It's aged cheese, so like hard cheeses. All right, tricyclic antidepressants, they can cause anticholinergic. Can't spit, can't see, can't pee, can't you know what, and postural hypertension. The tricyclics are they're neurotransmitters. They increase the action of neurotransmitters. So serotonin is the neurotransmitter that is lacking in depression. Okay. Then the SSRIs came along and they work faster than Mayos and tricyclics. Okay. St. John's wort, if you're going to take that, you cannot take SSRIs or Mayos. Okay. What is serotonin syndrome? Okay, so that happens about 48 hours after taking the medication. And the symptoms include a change in mental status, tachycardia because the body's under stress, fluctuation in blood pressure, and hypothermia. So they will have a high temp. Okay? All right. How is it treated? With medication, administering IV fluids. I don't know if you remember at the beginning of the semester when we talked about dantrolene, so that's a medication that might treat that. All right, elective convulsive therapy is a very good treatment. We're gonna it's been the cornerstone for many years. Okay, they have treatments 8 to 12 times over a course of a couple weeks. Now, how it works is the ECT therapy puts the patient in a seizure. Okay, they discovered a long time ago that after patients had seizures, they were in like a better mood after that postictal state. So they mimicked it for patients with depression. Okay, now you need to know the pre-procedure teaching. They need to be NPO for 6 to 8 hours. You need to make sure the informed consent is on the chart. All the things you do preoperatively are pre-procedure. Remove dentures, jewelry, glasses, contacts, and hearing aids. Patients avoid, so everything you do pre-procedure. Explain to the family that after they're going to have short-term memory loss and they're going to have to reorient frequently. Okay, so how do you know it's effective? Because it produces a grand mal seizure that lasts 30 to 90 seconds. Okay, that's what the goal is for the therapy. After, you're going to do post-procedural vital signs. Remember the frequency of post-procedural vital signs. Q 15 minutes times 4, Q 30 times 2, Q 1 times 4, okay? Um, and then the data collection for somebody with depression, you're going to ask about the appetite, the weight, their mood, um, if they can concentrate. The priority outcome is you don't want the patient to hurt themselves or others, okay? What happens is once patients get medicated, they may feel they have more energy to devote to harming themselves. Okay, so you need to be mindful of that. If the patient's too tired to get out of bed, make sure you're empathetic. I mean, don't say you're lazy, etc. Encourage and assist with ADLs if you have to. Don't threaten or remind them of their deficits. If somebody's non-compliant with the medication, the initial side effects of drowsiness and nausea may discourage long-term compliance. So you have to have a conversation about that. To prevent suicide, suicide precautions, active listening. Okay, so no belts, shoelaces, bras, anything that they could hurt themselves with. They'll be in a room without mirrors or glass. So that's really important to prevent in somebody that has depression. All right, that's it for mood disorders and anxiety.